Good morning, everyone, and thank you for joining us. I appreciate everyone is busy this morning, but welcome to this webinar, the first one we've done like this for a little while. This is hosted by ADSS Cymru in association with the National Commissioning Board and Welsh Government, really to examine in detail the COVID-19 support for commission providers. As Rachel's already alluded to, my name is Dave Street. My day job is Director of Social Services and Housing with Caerphilly County Borough Council. But as part of my role, I also co-chair the National Commissioning Board for Wales. As a Director of Social Services in Wales, I'm a member of ADSS Cymru. ADSS Cymru is the professional and strategic leadership organisation for social services in Wales, aimed really at directors, heads of service and third-tier managers. Really those senior staff who have responsibility for delivering social care services across Wales. At any typical time, that's a group of more than 100 social services leaders across the 22 authorities. As I've referenced, for some time now, I've been the co-chair of the National Commissioning Board for Wales. That's a role that I share with a lady called Carol Shillabia, who's the Chief Executive for Powys Health Board. The NCB was established probably around 2012 with a broad purpose of improving the quality of commissioning in Wales and developing effective practice in relation to integrated commissioning. The board's a fairly eclectic bunch, whereas I've referenced ADSS Cymru. There are representatives from local government, the NHS, regional commissioning leads from regional partnership boards, the National Provider Forum, third sector representatives, Welsh procurement officers, Social Care Wales, CIW rather, and the Welsh Local Government Association, along with colleagues from Welsh Government. So a pretty rich partnership in that sense. As I said, big thank you for joining us this morning. At the moment, we've got just the best part of 80 people on the call, so ordinarily this would be a big room in a hotel somewhere in Wales. Sadly, those days are over for at least the time being, so I'm sure you're all packed up in your front rooms and offices participating at the moment. I think one of the pleasing things around today's attendance is really the mix of people that we've got from the strategic partnerships. As far as commissioning itself is concerned, we've got to be honest, not everything was perfect within the care sector before the COVID-19 pandemic struck. But what we have seen as a result of that pandemic is some of the relationships that we've had really come to the fore, and we've borne the benefits of some of those in the close working between providers, the third sector, and indeed statutory and government services. What we want to make sure about now is that we learn from what we've gone through over the last 4 or 5 months, and really be more prepared should anything transpire in the next 6, 12 or even 18 months. And obviously that is a position that we're not particularly clear on at the moment. What we have seen over the last few months is really the challenges we've faced as commissioners and providers and regulators, etc., almost felt like an hour by hour basis, never mind day by day. And it's to everyone's credit that despite that level of uncertainty and at times what has felt quite chaotic, the work that has been done across Wales to protect the most vulnerable people in our societies has been absolutely exemplary. The support for commissioner providers guidance really evolved through the management of that COVID-19 outbreak. It was produced prior to it, but it's certainly been evolving as we've learnt from some of the experiences that we've set out. And certainly in terms of our recovery planning and our dialogue amongst statutory partners and regulators, how are we going to build on that in terms of our commissioning progress is going to be key. So as you'll see from this agenda this morning, this really is an opportunity for us to look at the core principles and values centred at the heart of that guidance, to look at some of the technical operational advice and how we deliver that in practice, and more importantly, to listen to the voices at the very front line of delivering our care services, to understand the challenges and the opportunities that exist from what has been an absolute unprecedented set of circumstances. So that's all you're going to hear from me in terms of my introduction. I'm now going to pass you over to Shelley Davis. Shelley works for Welsh Government and is Head of Partnership and Integration. And Shelley's going to talk to us about the strategic view of commissioning. Thanks, Shelley.
Thank you, Dave. Yeah, so that was a really good overview, Dave. And I think what I'm really clear is that commissioning, good, effective strategic commissioning has got a clear role to play, both in our response to COVID, but also as we plan for the recovery journey. And just to introduce myself, those people who don't know me, I'm a secondee into Welsh Government at the moment, and I head up the work around the Integrated Care Fund, regional partnership boards, pooled funds, commissioning and market stability. I've come in from Powys County Council, where I was a commissioning lead for children, so commissioning is very much my background, and I think collaborative commissioning, because I've always done it in a partnership arena, and this is very much something I'm passionate about how we take a relational approach to commissioning and make sure we all very much work together on doing that. Can we go to the next slide, Rachel, please? I think I just wanted to reflect a little bit on the journey we've been on since February time. What a journey. I think it's knocked everybody sideways, and I think, you know, there have been moments and there continue to be moments where it feels still very much like firefighting, and in those moments it's very easy to get down into the detail, get absorbed by the day-to-day, and really difficult to protect that time to step back and look at that strategic position. And I think as strategic commissioners, it is really important we find ways to protect that time, to do that horizon scanning, to check what's coming next, to check the implications of what it is that we're doing, and make sure that we're still on track. I'm really aware that we've got a mixed audience on here today, so forgive me for those seasoned commissioners who know this all too well, but I just felt it was useful to go back and reflect on that commissioning cycle that we all know so well, that guides our work, and just really think about the strength that gives us in providing a clear methodology and rationale for our approach as commissioners. And although that cycle might be condensed in an emergency crisis, so, you know, when we're having to respond very quickly to things, we are still trying to analyse the information and the level of need that's come into us, plan for the best way for meeting that need, getting on and doing that in the most efficient way, and then considering what have the impacts been of that action that we've taken. And although, as I said, in the COVID arena, it's been very much condensed, we've run that cycle very quickly, I think there is something as we move into the recovery process, we need to be able to run that cycle at a sort of a bigger, fuller pace and do some of that rechecking. What has COVID done to our key population groups? What has been the impact? How have the needs changed? What learning have we had from COVID that actually means that we could plan to meet some of those needs going forward in a slightly different way to what we used to do? And then, you know, what is the best way through the new partnerships, relationships, models that we've developed, what are the best ways to actually meet those needs, and having that continual review. So I just thought it was important to try and reflect on trying really hard to protect that little bit of time for that strategic horizon scanning whilst we admit putting out the flames. Could we go to the next slide, please, Rachel? Just want to reflect as well on some of the underpinning principles under the Social Services and Wellbeing Act, which very much most of well, everybody in the line should be aware of, and that act really ingrained in us all the focus on early intervention and prevention, integration between services, voice and control and co-production with partners and citizens and carers. And I think the real success to effective strategic commissioning is that partnership between commissioners, providers and the citizens, and we have to really focus on getting that right. I think while we've been firefighting, there's been times where that partnership has felt difficult. We've had to make very rapid, quick decisions. We had moved to a culture much more about do with rather than do to, and I think in an emergency there's been times where it's felt maybe a little bit do to, and we have to make sure we don't lose the progress that we made, and that as we move towards the recovery journey, we go back to that do with, engage with our citizens, engage with our carers, engage with our partners to make sure that we're reshaping the future in a collaborative way. I think one of the things I would say is that what I've experienced so far from where I sit has been a truly collaborative effort. And just to congratulate everybody, I think providers and commissioners have worked together remarkably in very, very difficult circumstances, but I have seen genuine collaboration. I have seen patience and understanding and trust. Yes, there's been challenges and difficulties, but they've been tackled with a real spirit of can do, and let's find a solution together. So really take my hats off to everybody, because it's not been easy at all. Can we go to the next slide, Rachel? Most people have seen this. This is the discharge to recover pathway that we've been following, and I would say most of our activity has been in this space about how do we effectively support people coming out of hospital and being discharged into community settings, and how we're able to meet those needs at a community level. And much of our work and activity, and the additional £10 million we put out through the Integrated Care Fund, has been focused on this part of the system. If we go to the next slide, Rachel, the commissioning guidance that we have in terms of focusing in on some of that really gives us some key principles and values for us as commissioners and providers to think about. So one is about how do we make sure that in following that pathway and trying to help people get safely discharged from hospital, we're doing that together and commissioning across health and social care seamlessly where we can. We know some of those conversations are difficult, but we really need to find those collective solutions so that the service user experiences a seamless journey through that system. Trying to make sure that health and social care and providers are all working together as equal partners, understanding that we've all got a real valid contribution to bring to that dialogue, and in terms of that planning and strategic commissioning, and really valuing everybody's voice and approach in that. Making sure that we share the information better across all of our partners to make sure we are doing that collaborative decision making. I think there's been some remarkable strides in some of the systems and protocols about how we've been able to share information, things that perhaps we've struggled with for years to get off the ground, and all of a sudden, because of the current conditions, we've been able to make those things happen. I think it's important we continue to build on those and not retrench back, because that share of information has been critical to allowing us to have the response we have. Obviously, one of the principles is about that transferring people home safely from hospital, and in line with the rehabilitation and recovery guidance, about making recovery everybody's business. So how do we make sure that whether it's a community volunteer, whether it's a domiciliary care provider, care home worker, or a district nurse, how do we make sure that everybody is thinking about recovery and taking that as part of their business and part of the role they can play in a person's journey to recovery. And then there's the time-old issue of parity of esteem. We know that there's a real challenge about parity of esteem between health and care workers. I think, through the NHS clapping and the key worker clapping that's happened Thursday nights through the media, I think it's really raised the profile of the social care workforce as a key workforce. We've provided £500 bonus payments for the social care workforce to really recognise the crucial role they've played. So I think, again, we need to make sure we don't lose ground and traction in where we've come to, and make sure that we continue to work to make that more equal balance across that workforce. Go to the next slide then, please, Rachel. So the final slide really is just to remind ourselves as commissioners that there's huge amounts of variables at the moment on our demand and coming in at us, and our capacity or our supply levels to be able to meet that demand. This was a slide that we developed through the Care at Home work stream that I was leading, to try and look at what all of the variables for our domiciliary care services, and what does that mean for our demand levels and our capacity levels now, but also what will each change that comes through the easing of lockdown mean, and how will that impact on both our demand and capacity levels. We are trying to work with partners to develop some tools to get out to you as commissioners to help you do some of that quantifying, giving some kind of key things to think about. We're working with Gwynedd who've developed some tools here, but also the NHS delivery unit. Many of you may have come across Linda Chandler looking at the modelling work, so it could be really clear what the demand flow coming through is going to look like, and what those needs may be around rehabilitation and recovery. So I suppose the plea is that we ask commissioners to be able to take that step back, to look at what's coming over the horizon, be thinking about what each change as we ease lockdown is going to have for what they need to commission for their service users. That was really all I wanted to say. I think, as I said, there's been some fantastic collaboration that's been going on, and we want that to continue and build from here. I think the role of the National Commissioning Board has a really critical role to play, as Dave said, in really strengthening our commissioning practice and approaches here in Wales. And I'm delighted to introduce Maria now. Maria joined us just in February and has been a real asset to us straight away in the National Commissioning Board. She's provided a really effective link and bridge between us providers and commissioners and has really helped us shape our response as we've moved through COVID. So I'm going to hand you over to Maria.
Diolch yn fawr iawn, Shelley, a bore da pawb. Thank you very much, Shelley, and good morning, everybody. So the slide suggests, and as that wonderful introduction was, I'm Maria Bell, and I was seconded to the Head of Policy role with the National Commissioning Board, taking up post almost 4 months ago now, just as the COVID lockdown was coming into effect. So a really exciting time, being home-based, coming into a new role. Next slide, please, Rachel. Thank you. So as the last 4 months have been a real whiz of activity in preparing for this webinar, it was a really useful opportunity for a time for a short bit of reflection about the role of the National Commissioning Board in supporting both service providers and commissioners through policy development and sharing of good practice. So my reflections included just how incredibly proud we all are and should be of our workforce and the incredible job that they've done. I just wanted to include the hashtag Social Care Heroes campaign there, really, to raise awareness of that. Also, how technology has reduced the barriers in our coming together to co-produce responses at a local, regional and national level to the threats and the risks that COVID has posed to us. And as our commissioning guidance says, to plan and deliver services during a time of crisis and uncertainty requires openness, trust, and the sharing of resources where possible. And there have been many examples of effective communication, of us making the best of our collective expertise, talent, and experience to find the right solutions for people supported and the workforce. But as the recent provider and commissioner SWOT analyses show, there are still more opportunities for us to learn and develop. Next slide, please, Rachel. So in using the guidance from England as a template, in Wales, we really wanted to use the guidance as an opportunity to respond to key issues that providers were advising us they were facing in light of COVID, but also share some of the notable practice that commissioners told us about at a local level so that they could be used elsewhere. So we included recommended actions within our guidance and asked providers and commissioners to feedback on the initial iteration of the guidance around any gaps, what they tried, what had worked, which informed the June guidance developments and the changes or the additions we made to those. So there are a number of things that as a collective we tried over the last weeks and months aimed at improving communication across our health and care system, building information and intelligence to inform decision making, and a number of new groups and networks that are working very collaboratively together. Next slide, please, Rachel. So there are a number of things that we've learned also in our coming together. We've learned what's working, what doesn't work, and there are a whole range of different perspectives on that. I feel that we've learned that we're better together, that co-production really does, that sense of being all in this together really does make a difference. And I suppose some of my reflections, some of my personal learning around this is that we've got some work to do together on business continuity planning to ensure future resilience. So we know that there were an awful lot of risks and challenges within the sector before we went into the COVID period, and we've got some work to do together to make sure that we can build resilience into our system. Next slide, please, Rachel. I think there's a number of things, as both Dave and Shelley have said, that we should be pleased about. So building on the learning that we've had, particularly in regard to some of our whole system business continuity in the face of such a significant threat. While some of the developments that I'm pleased about are not without their challenges, I feel that there's much to be celebrated about the joint effort that's gone into keeping our health and care services open and effective. So as mentioned, our workforce have gone above and beyond what could be expected and have proven themselves to be national heroes. And there's real evidence of joint work across independent sector providers, local authorities, health boards, public health wells, CIW, all working together in the face of very immediate threats and workforce shortages, and also collaborating on a range of workforce support opportunities around ensuring that our workforce maintain their mental, emotional, and physical well-being. We've developed and refined processes for the provision of additional PPE free of charge, and work is ongoing to look at that in the future. We've worked together across Wales Government, commissioners and providers to build the case for additional funding, with a commitment to co-produce guidance for a hopeful next phase of funding. And President Kennedy in 1959, I believe it was, advised a college fundraiser that the Chinese symbol for crisis contains two characters, one representing danger and the other opportunity. So one of my personal reflections is that this crisis has driven opportunity for change and innovation that we can build on to deliver our continuous improvement ambition. Next slide, please, Rachel. So some of the things that we collectively, the board, will be concerned about is the impact of the COVID virus on family carers, those people that have avoided health and care services out of fear of contracting the virus, the likely post-COVID rehabilitation demand, how to manage longer-term additional demand, pressures and risks with less money. Also concerns about how we achieve the perfect policy balance. A big part of the commissioning board's role is around supporting that national policy development. But how do we achieve that perfect balance of policy with calls from some for real absolute clarity and prescription, and others for discretion and the ability to work flexibly? So how do we work together collectively as a board to achieve that balance? And it's always very hard to gain consensus across local authorities, health boards, providers, Wales Government regulators, and something for the board to continue to talk about how we get that perfect policy balance right. And the worry that when the imminent concern, fear, threat of COVID is over, that we return to how we've always done things rather than continue to build on our learning. Next slide, please, Rachel. So as our thoughts turn to reset, recovery and or resilience, we have an opportunity to reshape the National Commissioning Board work programme. And I welcome the questions that we've asked you to send following today's webinar, and indeed we've had some in advance. And I understand we hope to evaluate the benefits of this particular webinar process, and so that we can discuss some of those with the board at their meeting next month, to ensure that they inform the work programme and that the board can deliver on a work programme that achieves its aim of playing a central role in building vision and setting a national direction for the commissioning of health, social care and wellbeing services in Wales. Next slide, please, Rachel. So I think we're managing to do relatively well on time, which was always a bit of a worry. So with great pleasure and a huge thank you for agreeing to take part in our webinar today, I would like to introduce our next speakers, who will be giving us perspectives from the front line. So firstly, we have Rhiann Stone of Pobble Group, followed, we hope, by Kath Titchin from Betsy Cadwallader University Health Board. Kath's experiencing a little bit of a challenge with the technology, but we're hoping that we can get across to Kath in North Wales. And then Sanjeev Joshi will be sharing his perspectives from the Karen Group, and Pete Tyson from Bridgend will share some of his reflections. So over to you, please, Shriyan.
Thanks very much, Maria. I'm Rhian Stone, and I'm the Managing Director of Care and Support in the Pobble Group. I've got a mixed portfolio of social care, registered social care and supported housing. We have got 228 services across 16 local authorities. So I'm just going to give you a few reflections on the last few months, and hopefully, raise a couple of questions really, which I think we need to address in our commissioning practices. So, I mean, first of all, I have to start by talking about colleagues. The incredible dedication, commitment, bravery and personal sacrifice that they've made is just, I think Dave talked exemplary, but I can't praise them enough really. Frontline staff and managers and leaders across Pobble who've just risen to this challenge, and just the passion and care and commitment for individuals has been incredible. So I think the big question for all of us is, how do we translate that newfound recognition into something meaningful going forwards in pay and conditions in our sector, but also in listening to the voices in the front line, really involving them in our sort of commissioning of services and what works. I think we need to make a step change in that direction. I mean, there's an awful lot of creativity at the front line. We've felt that our care staff have been more empowered in this situation, and what we've seen is the results have been amazing. I think similarly with our customers, it's been a much closer working, I think, more intense working between staff and customers, and lots of our services, supported living services, etc., have been like little families, created a real family feel, and the creativity of the activities and hobbies and involvement and things of people has been incredible. So I think there are quite a few sort of, I think, sacred cows and things that we can start to say, well, actually we didn't want that going forwards. So one of those has been about day services. I think as we've kind of really stepped up with people doing creative activities and hobbies at home like the rest of us like to do, quite a lot of our customers have said they don't want to go back to the sort of day services and that type of provision. We've been able to support people digitally in different ways, and connections with family and friends, and much sort of upskilling for staff and customers really of the sort of digital space, and that's created lots of opportunities, which again we don't want to lose. I think it has been a very difficult period. It hasn't all been easy. I think with some collaborations and commissionings, particularly at the start, I think it's easy to forget how frightened and we were in the unknown right at that early stage. But I think the fluidity of collaboration and creativity has been a step change, and partners have found it easier to get together on Teams or Zoom in a way that we couldn't before, because people could, you're trying to arrange these meetings and people couldn't make it. So there has been, particularly in the latter months, I think, a great improvement there in how people are working together. I think what I would say though is I think we do need to make a bit of a step change in the co-production and collaboration. If there's one thing that's taught me through this period, is just how much innovation and creativity there really is in that front line. And I think capturing that now and involving people much more in the commissioning process going forward and in the reflection piece that we're doing now is going to be critical for us to design services differently going into the future. So those are sort of the two questions really I think we need to ask, is how do we really take forward that co-production? And I think there's a way to go on that, if I'm honest. And how do we provide the recognition, ongoing recognition for the sector and improve the pay conditions and just respect for those staff, and that we've got a long way to go, so we need to do those things now, but this is a marathon, not a sprint. And you know, people are it's really important that we make sure people feel valued right now, so because we're going to have to keep going for a long time to come. So those are my just brief reflections on some of the things we've seen at Pobble.
Thank you very much indeed, Shrian. And our next speaker, we're hoping we can cut across to Catherine Titchin. Kath Titchin from Betsy Cadwallader University Health Board. We may need to ask Paul or Rachel to unmute Kath because we know she's joining by phone. And if we can't hear Kath, as a fail-safe, I do have Kath has sent me through some of the things that she was aiming to say. So if we can't manage to get Kath's voice across the system, then I'm hoping that I can give a little bit of feedback on Kath's behalf. Okay, so I'm not sure, Paul, Rachel, if we're able to get through to Kath. So just while you're perhaps still working on some of that technology, if I make a start on Kath's behalf, and I'll be delighted if she's able to join us to pick this up when she possibly can. Okay, so sorry, I just had a message to say we're struggling to be able to stream through Kath's voice. So with permission then, if you don't mind, Kath, as a fail-safe, did send some notes through. So Kath asked, was looking again at what they've been working on in Betsy Cadwallader University Health Board, what has been learnt, some feedback really to the webinar today and some of the next steps that are being taken forward in BCUHB. So Betsy Cadwallader University Health Board has been looking at providing COVID urgent support for independent providers and CHC services. There has been an integrated mechanism in the silver gold command structure with a specific work stream reporting through primary and community care cells. And so the care home cell has had senior health board chair hosting the health board response to supporting with COVID, but recognising from the start that a whole systems approach was needed. So the former continuing healthcare improvement group was stepped down in favour of bringing forward the care home cell, and a number of partners were invited to join that cell. So partners invited including primary care, health board community, continuing healthcare senior managers, health board contracts leads, local authority senior managers, regional partnership board representation with input from medicines management, palliative care, public health, CIW and provider voice. So in March 2020, Betsy Cadwallader University Health Board set up emergency daily care home cell meetings, which as systems were put into place, stepped down from 3 times a week to 2 times a week weekly, and have now been paused for a thinking around a longer term structure for strategic and operational whole system support again feeding into the North Wales regional approach around recovery and reset and resilience. The cell has responded to a variety of issues in an effort to coordinate systems and responses, and being really responsive to the issues that were being raised by the different partners and the operational requirements. So looking particularly at PPE guidance, so access and supply issues, coordinating support in early supply chain challenge times, responding to provider inquiries, concerns and requests. Again, the Health Board in North Wales started initial work on a provider brief, which did then stimulate the discussion about having a national provider brief, and the communications that you will receive through ADSS now on a weekly basis. And the Health Board identified a single point of contact for finance and contract issues. There was work around infection prevention and control guidance and support from the Health Board with services experiencing infection control issues, and environmental health officers supporting that joint work. It was also support and looking at wider supply issues around food and staffing, and taking a lead around COVID testing, so the coordination of mass testing, track and trace links. Also a lot of work going on through the cell around data collection, so being clear across all partners in North Wales, in terms of regulators, local authorities and the Health Board, what information was required, both to make decision making at a commissioning perspective, but also you know, what would help, what could be shared, what information was required in order to provide the best support and help for the providers. And so a data collection system has been set up, an agreed data set and a tracking system with daily local authority data set calls, integrating that with the Environmental Health Officers Protocol, and a whole system developed, hosted by the Health Board in the form of a SharePoint dashboard. Also significant work collating and supporting shared practice across Home First bureaus to support Wales Government discharge guidance, with single MDT points twice daily for decisions in principle. And there have also been a range of clinical support tools, such as SPAR clinical handovers, a situation, oh gosh, this is going to be writing background, actual and results. Kathy will be able to tell me off about that. Resus guidance, aerosol generating procedures guidance, delegated care protocols, a range of different clinical support tools there to try and help the whole system. So in terms of some of the things that have been learned, whilst risk puts local authorities as kind of responsible for market sustainability, it's really clear that health role has a real link on many more enclosed settings than they necessarily directly commission into, and that integrated work is really, really important. Older people care homes may no longer be categorised as residential or nursing, but it's really important that there is that joined up response, because intervention, that there are clearly differences in the interventions. So if there are registered nurses in the home or not, then the Health Board needs to continue to support operationally, but whilst retaining that distinction. Providers have massively stepped up and supported the system, and we need to have more emphasis on supporting their independence to deliver. Some of the other learning is around having a clear understanding across the health and social care system and the different roles within that, about the registered manager and responsible individual responsibilities, and proactively supporting services in a way that encourages those registered managers and responsibilities to perform their roles. And so again, that links to business continuity planning and escalation support. So in terms of next steps, the slide is telling me, that the intention is to look at coordinated monitoring and independent provider new quality contract commissioning methods. So again, continued learning about the benefits of that coordinated approach, reducing the burden of monitoring, and looking at the supports provided at different levels of risk and escalation, and the importance of that data collection as a two-way process embedded into the system as core practice. Looking at infection prevention control bubbles and learning and development support, particularly in a big message really around resilience as we move into the winter period, and heavily promoting flu vaccination, the benefits of flu vaccination for care home, well, for staff, for the care sector staff, but also the people that we're supporting, and looking at those threshold crossing triggers. So in what scenarios would we ask district nurses, GPs, regulators, etc., to cross the threshold of a care home? So understanding that risk stratification and required response for support, and also looking at the capacity modelling and monitoring. So making sure people are going into the right pathways and looking at system sustainability. So I do very much hope, Kath, that I've done your quick notes some justice there, and I apologise for any errors that I've misinterpreted any of those notes. Thank you for bearing with me and letting me speak on the hop. So with that, I think we're going to hand over now to Sanjeev Joshi. Thank you, Sanjeev.
Hi, thank you for that. Good morning, all of you, coming up to midday. Very interesting listening to all the presentations prior to this. What I'm going to do is try and share with you the short journey through COVID in the last few months as a provider. And the journey we've been through is probably very similar to the journeys of other care providers in the sector. I know for certain that the majority have had a similar journey because we talk to each other. One of the best things that has happened during this period in what is an overall a very difficult situation is the collaboration and exchange of information between providers. We've got our WhatsApp groups, and suddenly providers in North Wales and South Wales and Mid Wales are virtually on first name terms and sharing and exchanging information and ideas that are very practical and have helped most of us. Our sort of awareness of COVID and the risks COVID posed for our resident communities probably was highlighted back in February when we saw on the news an outbreak in a care home in Seattle. We then heard also of outbreaks in care homes I think it was in Korea, but what brought home was the situation that was in the news of the Spanish nursing home, which had been abandoned, and a horrible experience there. And like most of the providers, we started to think very hard about the risks to our resident communities. And although there was guidance out there about the high mortality risks attached with anyone having underlying conditions or over the age of 70, it came home to us that our residents were in a very high risk category, not only because of that, but because they were also in confined environments. So a lot of our care providers started to think outside the box, try and research and find information wherever that was available, and not just relax and follow guidelines that were being at the time prevailing within not only the health sector, but within society in general. And we moved very early On 12th of March, we closed doors to visitors. And in the early days, that was a very, very difficult decision to make. At the time, there was a lot of resistance. The media and the perception was that the risk isn't there and that we were overreacting. And there was challenges from families as to their rights, etc. And we recognized that it was at the time a very difficult decision and a risk attached, as we appreciate the importance of the emotional well-being and the family visits and the attachment that our residents have to that. Equally, very, very worried. We were very worried at the time about the infections coming into our homes. So it meant also health visitors and all the others were stopped for coming, or if they did, it was in exceptional circumstances with very strong screening. We did the same for our staff. We brought in very early hand washing portable sinks at the entrance, and every staff member was not only screened, but to ensure discipline, we recorded and monitored and did spot checks on the hand washing procedures. Similarly, we thought long and hard about the infections coming in via staff from the community and put in place provisions such as renting accommodation in case our staff members were not able to return back to their homes because either there were family members showing infections or symptoms of infections, or their family members may have been at high risk of it. So other care providers put in similar processes. What we tried to do was ensure that the staff members who worked, for example, at the same site. We didn't allow for agency nurses or agency staff members to come in, as we recognized very early on the risk of the infection coming from different sites or from hospitals, workers in hospitals. Similarly, what we did was we tried to have staff work shifts, shift for 3 shifts at a time, so 3 consecutive days followed by time off, etc., to try and reduce the risks. And some of those measures paid off, others didn't. Unfortunately, in our group of 14 homes, 2 sites did have major outbreaks. What we did as a group was try and learn as much as we could from those outbreaks and apply them to other homes, and that did pay off. What also paid off was listening and learning from the experiences of other care providers, and at the same time working with the authorities. Very early on, we recognized that testing was key to preventing, and we pushed hard for testing, and that was an area of frustrating. It still is. We don't think that we're at a point where testing within our homes should be at a level that is appropriate, commensurate with the risks that we have. PPE was another big issue early on, and there were some very, very difficult decisions and made at the outset. I recall having to authorize a payment of £10,000 to an organization in Manchester, not knowing them, buying N95 masks, knowing that they weren't on the guidance sheet. But those were the sort of risks we had to take in those early days, not knowing when a stable and a recommended supply would be available. We took similar actions on food supplies. We decided very early on, we have about 600 residents. We decided that we were going to invest and buy 1,200 meals, ready-made meals, frozen meals, just in case we hit a bump where physically, due to logistics, supplies were not available to our homes. We certainly couldn't have a situation with no food at each one of our care homes. Similarly, there were lots of decisions made, risks and decisive decisions had to be made early, and then reinforced and longer term solutions looked for. The biggest asset that I would say that served us well was our staff, and I think Rian reinforced that. We had to, our staff worked miracles. The incredible lengths they went to, no doubt has paid off. Our job was to support them with not only support as management, but to provide resources and to try and understand how best we could protect them and to ensure that they continued to deliver what was an incredible service that they did under the circumstances. The situation has stabilized, but the efforts and the tasks ahead and at present haven't reduced. There's a lot of thinking within our organization, preparing for what could be a worse situation this winter. And I think Maria and Shelley have already alluded to the risks of the pandemic combining with the seasonal issues such as flu and so forth. Also, the virus, we understand, thrives in a colder environment. And we see that although we've suffered significantly, we see over the last period, an analogy would be we've had a tailwind and we've somehow come through it. Going into the winter, we're going to have a headwind. We may be better prepared, we may have better PPE, testing facilities, etc., we hope, but there is a lot of work to be done on trying to keep our communities and residents safe. For example, within our organization, we've been thinking about how infection control would work better, smaller cohorts, smaller bubbles within the home, use the facilities we have in the best way possible for trying to contain and restrict the infection coming in. Means looking at staff cohorts, splitting them, etc. And these are the challenges where, as providers, we're not going to be able to handle them on our own. Funding is going to be a major issue. In the early stages, like every other provider, we did not think twice about making available resources, despite the fact that our occupancies, which is our main income source, were dropping. We stopped admissions very early in March. Our homes are now at 10% lower occupancy than they normally are, which most commissioners will recognize is in a long-term and unviable business. This is why we're going to need to have to think very differently going forward on how we deliver, and the strength of the partnership with commissioners is going to be vital in us succeeding. It is going to be a prolonged COVID experience, we believe, this winter, perhaps running much longer than what we saw in the first wave, perhaps not as serious in the sense of casualties and mortality in a short period, but nevertheless, if we do not prepare for a prolonged period, the numbers may add up to a similar level. And I would urge that this is the time when we do have to have that step change. I think Rian mentioned that. I was very impressed with Maria's slides, and it looks like our issues at a ground level are being understood. However, for us providers, that message isn't coming through, that feeling isn't coming through, that we are being supported to the level the intentions are. Just to highlight, in the middle of the pandemic, the last wave, it felt like we were valued and respected more by families the public, the local community, the local businesses than we were by the commissioners. Now, if it is a matter of communication or it's resources, this is something we're going to need to have to sort out before we go into the next one. Families were so supportive with gifts, etc. We had the public, we had strangers knocking on our doors, providing us with visors, sanitizers, all sorts of help. And really, more than the resources they were providing us, it was the acknowledgement and the appreciation of how wonderful a job our staff were doing. And I think we need more of that going forward. We need empowerment. We need the understanding. One organization, I would say, as a national organization that we feel has been very supportive and flexible is CIW. Usually, with the sort of risks, the sort of changes we've made, we would have expected far more serious consequences for the sort of actions we've taken. They have been very sympathetic, very supportive, and I would hope that that sort of approach is also taken on by the commissioners, who need to understand the complexity, the details, the pressures at a local level, at a care home level, what our frontline staff are going through, and to be supportive. That is the best way we can get through it. Thank you.
Fantastic. Thank you so much, Sanjeev, for your candidness, and you've given us an awful lot of food for thought for the next commissioning board meeting. So I'm hoping we can collate those points and discuss those. So thank you so much for your openness there. So I'll hand over now to Peter Tyson to give us some feedback from and reflections from Bridgend. Thank you, Peter. Pete. Just need to make sure you're unmuted there, Pete.
There we go. Hello, can you hear me now?
Loud and clear, thank you.
Loud, fabulous. And do you know what? My opening line was, oh, good news, I'm not on mute, which is the strapline at current times. So a bit of irony there. Thank you, Maria. Yeah, and probably should point out before I start, these are very much kind of my own personal reflections as a commissioner during this time, as opposed to the views of Bridgend Council, although I'm not planning on saying anything too contentious. I think in the media and in various meetings recently, there's been a lot of talk about there's been a significant spotlight on health and social care during this time. And I definitely kind of go along with that. There's also been what I would see is a bit of a microscope on it as well. And sorry about this. Yeah, so what I mean by there being a microscope on it is all the good bits really have been kind of magnified during this time. Sanjeev and Rian definitely put it across a lot better than I could in terms of with the workforce, etc., how things are working there. But I think the microscope has also kind of highlighted some of the gaps and challenges. There we go. But it's also highlighted some of the gaps and challenges and issues that the health and social care sector face at this time. So I'll talk about kind of some of the positives and challenges in a bit, but I wanted to really talk about the commissioning guidance initially, really. And generally, really valuable and helpful resource. When COVID first started, they were particularly, I'd use the word scary times, to be honest, unprecedented challenges, etc. And what I found the guidance gave us was a bit of a safety net and something to fall back on. What I really didn't want to do and don't want to do is for any guidance to be given where it's Pete Tyson from Bridgend said. So having that kind of guidance behind us, like I say, was something to fall back on. That alongside the national guidance that was produced and also the public health guidance, I think it was a really kind of rich and valuable resource. A key benefit of it was that the full application kind of wasn't mandatory in any way. And I think that's really important because as 22 independent local authorities, 7 health boards and regions, we do work very differently. We are all set up very differently. We commission differently. We all have different Section 151 officers, and we all receive different legal advice as well in terms of what can and can't be done. So I think it was really important that it was there. You could utilise kind of bits of it, sections of it. So that was a real plus of it from my own personal perspective. I think with regard to the guidance, I think it's absolutely essential that it complements other guidance. So kind of subsequent to that, we had the 50 million with regards to the funding from Welsh Government for adult social care. So we just need to really make sure that we square off. So if the guidance, the commissioning guidance is telling us that you can do A, B and C, then we just need the guidance to be 100% clear. That's okay, well, is that funding, are we able to use that for the A, B and C, or are there potentially kind of local cost implications? So I think it's just really important that those two kind of complement and there aren't kind of any anomalies or potential contradictions between the two. In terms of my own reflections, as any review or evaluation that's undertaken, 99.9% of the time it comes back to communication. When things have gone well, it's because there's good and effective communication. And when things have gone not so well, it is often due to a lack of or poor communication. I think during this time, the level of communication has been absolutely great in terms of the key updates, guidance changes. I'm getting it in triplicate. So I'm getting it via corporate director from ADSS, from the head of service who's an RI, so receiving it in the RI role, and also the Pan Wales network as well. So I think the level of communication has been great. There is a but with that. I think that the timing of the communication, in particular the significant PPE guidance change, was a huge challenge for us kind of as commissioners and kind of local authorities were identified as lead organisations in respect of the PPE. I think receiving it just before the Easter break was a real challenge. I won't go so far as saying I think that week or the 2-week period was the hardest period of time I've had in my career to date. So potentially looking forward, whether there's an early draft version, a quarantine version that can be done. I know we're doing something similar with regard to the £500 payments. I think that's a really good idea in terms of a quarantine version. So something like that I think would be really welcomed going forward, because it did feel a little bit on the back foot with that one. Another real positive in terms of from my own reflections is the relationships and working together has been really positive. That's a commissioner provider perspective as well. So what we've done in Bridgend is the daily check-in calls. And what we did as part of that was we realised that at the outset there were lots of organisations who needed some key information. There are ourselves, health colleagues, environmental health. So we had some discussions beforehand about, okay, well, who gets what information, kind of when, and how we share that. And I think that has been another real positive as part of this, is working with our key partners, such as CIW Health and Environmental Health, allowing us to share some of that really important data. I know before now we've not been able to do it. I think that there's GDPR was often cited. I think what this has shown is that if it's done in an appropriate and safe way, I think it's really beneficial, and it's been a massive help for us during this time. The provider relationships I think have been really positive. We've set up an information kind of sharing portal as part of this right at the very outset. And as part of that, the providers just sharing information, sharing ideas. There was a real peer support network, and it was really heartening to see that. So what could be seen potentially as business competitors, there was none of that in the slightest. It was all real working together. So that was really positive to see as well. I mentioned the microscope earlier on. I think that really has exposed the fragility of the sector. And Sanjay touched upon this earlier on when he was kind of talking. I think without the 50 million that was made available from Welsh Government, I'd be genuinely concerned about some of the providers kind of coming out the other side of this. But with regard to that, I think there are still some gaps in that 50 million guidance in terms of kind of with obviously some of the health fund placement, some of the health costs. I think that's something where there is still kind of adding to the fragility and uncertainty to a certain degree. the approach we've done with PPE, where the kind of local authority or kind of the key partners have responsibility for the providers on their patch, I think that's generally worked well. So whether there may be potentially scope for that type of methodology to be applied in terms of the financial support, but I know it's all kind of being reviewed by NCB and colleagues as well. But yeah, I think that's something that we could potentially kind of fine tune going forward, definitely. So if I were to summarise, I guess in one word, how I felt as a commissioner during this time, I think it's reactive would be a word I'd use. And I think Shelley mentioned earlier, she had the slide showing the firefighters. It's not a position we as commissioners like to be in. We like to be planning, we like to be analysing, we like to be kind of looking forward, doing the horizon scanning and stuff like that, but it has felt very much, we have been fighting fires. Obviously this is an emergency, so it's been necessity. But we've touched upon winter pressures moving forward, potential second waves, etc. So we kind of really do need to, yeah, hopefully get everything lined up. I think the rapid reviews that are being undertaken is excellent timing for that, the work that John Bolton's doing. We really need to take this opportunity now to identify the good bits, kind of fine tune and make sure all the guidance that's out there is kind of complementing itself. And yeah, those tools and guidance, like I say, for commissioners, they are absolutely vital. Yeah, basically in terms of how we can work effectively moving forward, really. And then ultimately it'll allow us not to be kind of working in a reactive way, being proactive and really being on the front foot and being prepared, really moving forward. So that's it from me. Thank you, Brian. Thank you for your time.
Thank you very much.
Thank you, Peter. That's very kind of you. I'm aware that the time, unfortunately, has got the better of us this morning. But can I thank particularly the four people who spoke towards the end of the session. I think those personal experiences are very powerful and very significant. And I think, you know, Rian's point there around being able to challenge sacred cows is absolutely spot on. And Sanjeev, I think your comments there in terms of your experience as a provider weren't always easy to listen to, but were extremely powerful. And I think Maria's right, form a very significant agenda for us as at the next National Commissioning Board. You will have seen on the agenda a question and answer opportunity. Clearly, we're not going to be able to do that now. What I would ask is, obviously, we have had some questions in advance. A lot of those, as you would expect, perhaps relate to funding and voids. But if you do have any other items that you'd like to talk to us about in the context of this webinar, if you could drop us an email either to Rachel or to Paul Pavia. Paul, his contact details are available. And if I could ask you do that by close of play on Monday the 20th of July, we'll then work with our partners at government regulators and indeed within service provision to get those frequently asked questions answered, and we'll get those up on the website and we'll notify you that we've done that. I'm aware that quite understandably we're starting to lose people now because people have got other commitments. Just to put this into context, we did at its peak have 95 people on the webinar this morning. So hopefully that's helped you with some of the challenges that you face going forward. It just falls to me now to thank everyone who's been involved in pulling this together. But more importantly, thank you for taking an hour out what I know are increasingly busy days. I'm sure we'll be revisiting this opportunity for further commissioning related webinars in the future. So many thanks. Thank you for your time and enjoy the rest of your days. Thank you.
Thank you.
Thank you.